కదా, అది కీ నాకు పంపిస్తాం మళ్ళీ. ఎట్లా దీన్ని Good morning guys. Hope you are all enjoying these enforced holidays. Be safe, and it's not enough for you to be safe. You are our health ambassadors. This is a very difficult time for all of us, and being a health care professional, we should rise to the occasion. You should safeguard yourself and your family and your friends and people around you. You should tell them most of the do's and don'ts. So you might be wondering why I am wearing this glove, even mask and other protective equipment, even when I am talking to you. So it's not enough if you tell to don protective clothes. You need to do it yourself and tell them, then it will be more effective. So most of you must have recognized me, or for some of you who have never seen me or heard me, I am Dr. Prasad, Professor of Orthopedics, Medicity Institute of Medical Sciences. Right. So we have seen what is a fracture, types of fracture, and general management of fractures. Now we are going into the specifics. So today we try to discuss something about the shoulder joint, humerus, and clavicle and acromioclavicular joint. Here we need to tell you what are the things we are going to discuss during our lecture. Shoulder and humerus injuries usually seen in our casualties, and what are the other injuries which are associated with the shoulder joint. And for each injury you need to know the mechanism of injury. So the mechanism of injury is very, very important when you want to manage it properly. So unless you know which type of movement or which type of violence causes this type of injury, you will not be able to treat it completely and satisfactorily. Then you need to examine the patient, physical examination. It should be from top to toe. You should never miss any other associated injuries. And once you make a diagnosis, provisional diagnosis, you need to resort to some diagnostics which will help you in making a complete diagnosis. Then management. For management, you need to classify what is the type of injury, and unless you classify, you may not be knowing the exact mode of treatment, and then how to manage that. And last but not the least, watch out for complications, and it's always better to anticipate them and take proper care not to get those complications for your patients. Usually we all see this is a photograph taken from net, and which clearly shows that the rider and his vehicle are far separated from each other, because we know how we drive when we are on roads. And I keep telling you guys that once we are on road, we are always in a hurry. We never go to our colleges or our schools or our offices in time, but we are running when we are on road. So this road rage should end. And most of you know that road traffic accidents are the commonest cause of morbidity and mortality in young adult individuals. So this is the commonest mode of injury for most of the fractures or dislocations or loss of lives. So here we will be discussing about acromioclavicular separation, clavicular fracture, scapular fractures, shoulder dislocation, and humeral fractures. Don't worry, I may not be boring you with all these things in today's class. So these are some of the things which you need to know. So that's why this slide is put. Coming to the shoulder anatomy, most of you know that these are some of the terms which are associated with shoulder joint. What is a joint? Joint is a place where more than two bones meet. So what are the articulating surfaces in the shoulder? Articulating surface of the shoulder here are the glenoid. Glenoid is a part of the scapula, and this is the head of the humerus. And most of you know that the ends of the bones at the joint are covered by a cartilage, a special cartilage, and this is called an articular cartilage. And these are some of the processes which are projecting out of scapula. This is called a coracoid process, and this is called an acromion. Okay, and the shallow glenoid is made deep by this labrum. So this is the labrum. So this is the scapula, and this is clavicle. This is another view with the muscles attached. Coming to acromioclavicular separation. So
just a minute. Video may not. వినిపిస్తుంది కానీ మీ ఫోటో ఇక్కడ రావట్లేదు. ఇప్పుడు ఓకే
కావాలా వస్తుంది
ఇప్పుడు వస్తుంది.
Yeah, coming to acromioclavicular separation, here the mechanism of injury, there is a downward force at the tip of the shoulder. So once there is a downward force acting at the tip of the shoulder, then there may be a strain at the acromioclavicular junction. So this there are some ligaments which are keeping this joint intact. So when there are ligament injuries, then definitely the bones which are being kept together, they get disrupted. So whenever there is a fracture of the clavicle or coracoid process, then you should examine for this injury. Acromioclavicular disruption can easily be missed. If you don't search for it, you may easily miss it. So coming to the normal anatomy of acromioclavicular joint, here you can see this is the clavicle, and as we have already seen, this is the acromion, and this is the head of the humerus, this is the glenoid, and this is the coracoid process. And there are some ligaments which keep this clavicle onto the acromion. These are the ligaments which these are called coracoclavicular ligaments. This is a medial head, and these are the coracoclavicular ligaments lateral. So you can see the rent here. There is a disruption here. Once there is a disruption in the continuity of the ligament, then only they can get separated from each other. Okay, so this is the acromioclavicular joint capsule. It's a proper joint, and you have a disc in between acromion and clavicular. So if this type of injury happens, then there will be separation between clavicle and acromion. Okay, so this is the normal anatomy, and this is the pathophysiology, how it happens. Coming to classification, every injury you need to classify, right? So this is into 3 grades, and the severity of the injury increases from grade 1 to grade 3. So grade 1, mild tenderness, mild swelling, and range of movements are full. So here you need not do much here. Give some rest so that the patient will be symptom free and he can go back to his normal activities. Grade 2 is moderate to severe pain because the damage is more, and clavicle is slightly displaced up. That means the more ligaments are getting involved here and they are injured. And grade 3, here more damage is there due to the injury of the other ligaments as well. Then the arm is kept in adduction and obvious deformity. You can clearly feel the clavicle is separate from the acromion. So coming to the pictorial description, this is type 1, type 2, and in type 2, type A, 2A, 2B, and type 3, 4, 5. So as you see, the damage is more in type 5 rather than in type 1. Here only minimal injury, and here it's injury is a maximum. So how do you take X-rays for this. There are AP shoulder with a tilt, just a Tiffany tilt. Here you can see the normal distance is around 1 to 1.3 centimeters, and if it is more than that, then it is considered, and patient should have a history of injury, and patient should have local symptoms like local tenderness, and sometimes there may be obvious deformity, it may or may not be there, and correlating with X-ray findings. Then only you can make a diagnosis of acromioclavicular joint separation. Sometimes if you cannot find any correlating evidence in the X-rays, you may have to resort to what is known as stress views. Here you need to ask the patient to carry some weights so that the arm will go down, and whenever there is a minimal disruption, maybe it can be maximized because of the stress, and you can clearly visualize that during X-ray examination. And sometimes there may be what is called os acromial. It is a secondary ossification center, and it's not a fracture, and it should not be confused with acromioclavicular dislocation or any other injury around this place. This is a clinical X-ray in a typical case of acromioclavicular separation. So this is the acromion, and this is the clavicle, lateral end of the clavicle, and the distance is clearly palpable. If you see an X-ray like this, and you can clearly palpate the distance, a clavicle much away from the coracoid, then acromion, and this is the coracoid. If you can palpate this distance clinically, and patient has symptoms and history of trauma, definitely a diagnosis of acromioclavicular separation is made. Coming to the management, as we have already seen, 1 and 2 usually conservative. How do you manage conservatively? We give what is known as a sling or arm pouch. Arm pouch, it encircles the elbow and keeps it together. Sling comes around the neck, and you can apply some ice. Ice will reduce the inflammation, and analgesia. Analgesia can be provided by local topical analgesics or by NSAIDs. And some physio. Once the pain comes down, the unaffected joint should be mobilized always, and you should wait for at least 6 weeks before you start lifting any weights, because this 6 weeks is mandatory time which is given for the ligaments to heal themselves. So because this is a ligamentous injury, so you need to give time for the ligaments to get better. So coming to the type 3 injuries, they are a bit severe, and you can need to resort to surgical management sometimes, and sometimes, very rarely, this is only for completion sake. Nowadays we are not doing this excision of distal clavicle or whatever, but these are some of the procedures which we can do. This is a screw with something like a tension band wiring. This is keeping the clavicle in place, because there is a ligamentous injury. Coracoid and clavicle, they are brought close together, and this wire is passed from acromion to clavicle. So keeping all these things in place, or you can have a screw from clavicle into the coracoid. In place of this does the work of the ligaments. So these are some of the salient points in injuries of acromioclavicular dislocation. Coming to clavicle, as all of you know, that it is the only long bone in the body which is horizontally placed, and all of you know that we have two skeletons. One is axial skeleton and another one is appendicular skeleton, and clavicle is the bone which connects this axial skeleton with the appendicular skeleton. And clavicle is very peculiar in that it has two ends, one medial end, one lateral end, and the development also, it is one of the first bones get to have begin ossification. It that does from 6 to 8 weeks in intrauterine life, but the ossification is completed more or less. This is the last bone to get ossified. So around 20 to 25 years. So most of you, the ossification is still not over. That means the clavicle is not fully strong. So there is a chance that whenever these young people, whenever they are injured, so clavicle is one of the commonest bones to get fractured. Previously, when I was a medical student, or when I was doing my PG, so we used to talk in just like, if God comes in front of you and asks you, I want to break one of your bones, which bone do you choose? Now we used to joke that I will say my clavicle, but not anymore. Clavicle is much more important in nowadays than when we were PGs. So why it has not become a prominent member overnight, but as we knew more and more about these things, then the importance of clavicle has risen, and nowadays we are not neglecting any of these clavicular fractures as well. So one more thing, peculiar thing about clavicle is the ossification, and the lateral end is formed by the membranous ossification, and the medial end is by the endochondral ossification. You must be knowing what are these things. Membranous ossification means the bone forms directly from primary cells, and endochondral ossification, before a bone is completely formed, there should be a cartilaginous skeleton on which this bone is formed. So clavicle has both these things. Most of the bones have only one type of ossification. Flat bones usually membranous ossification. Most of the long bones, they have this endochondral ossification, but clavicle is only the bone which has both. So, and it's one of the long bones which doesn't have a significant medullary cavity. So if you want to fix a clavicular fracture by means of intramedullary device, you are in for trouble. So you need to know some of these things before you go to the treatment of these clavicle fractures. So this acts as a strut, and it keeps the upper limb away from the trunk. So once the upper limb is away from the trunk, it can perform more functions and more effectively, rather than when it is close to the trunk, then its mobility is limited and its functional capacity is also limited. So how a clavicle can get fractured? Most of the, these are some of the mechanisms which can be applied to most of the bones in the upper limb. These two. One is direct blow. Direct blow is taking a thick club and hitting the patient directly over his shoulder or over the clavicle itself. Or most of you guys are very much fond of these acronyms. Whenever somebody says sends you some joke and all, you say LOL, something like that. So we coined something for you. See, this is we call it FOOSH. That means fall on outstretched hand. So this is otherwise known as FOOSH, fall on outstretched hand, and this is one of the common mechanisms for most of the fractures of the upper limb. So don't ever write mechanism of action in lower limb fractures. Okay, lower limb fractures, the mechanism of action is different, but whenever you are falling, the first primary action which you do is you want to protect your fall. So how do you protect your fall? You protect your fall by means of thrusting your upper limbs and try to reduce the intensity. So once you do that, then definitely you will be falling on outstretched hand. So once you fall on your outstretched hands, this is one of the common injuries which can occur. So this is mechanism of fracture of the clavicle. So these are some of the types of fractures of clavicle. All of you know that types of anatomical types of fractures: a transverse fracture, oblique fracture, comminuted fracture. So the type of fracture of clavicle depends upon the severity of the injury. If the injury is very severe, suppose that the patient is involved in a high-speed vehicular accident, then definitely patient may sustain these injuries. But the patient fell down when he is walking, or somebody pushed him and he fell down, and he may sustain something of this sort. Physical examination. Once you see a patient may have a gross deformity, something like this. The clavicle, the fragments of clavicle which are it's just underneath the skin. It's very subcutaneous bone. So we can usually feel the entire length of clavicle. So if there is a fracture, you can easily see and feel the fracture. The deformity is very, very obvious. So there will be gross deformity if there is a gross displacement, or if there is a severe injury, then the deformity may be more. And if you palpate, definitely you can feel both the fragments moving independent of each other. Usually you cannot move a clavicle separately, but once you are able to move, this is called abnormal mobility. So when you find a deformity, and you can feel the crepitus as well when you are trying to move, but never ever do it in an acutely injured patient. Never try to elicit crepitus or abnormal mobility by the patient coming to you and telling that history of trauma is there, obvious deformity is there. No need for you to test clinically whether abnormal mobility is there or whether crepitus is there. You need to test for any obvious neurovascular deficits distally. Okay, so if you don't find any neurovascular deficits, then definitely you can directly send the patient for X-ray for radiological diagnosis. So while asking for the X-ray, you ask for two views, anteroposterior view and cephalic tilt, so that it can be clearly seen. So can you see the fracture line here? So this is the medial end and this is the lateral end, and the clavicle has two curves. It's like an S-shaped bone with two curves, and usually the most of the fractures occur in the middle third, and very rarely either medial or lateral end are involved in the fractures. It is always, most of the times, 85%, it's usually in the middle third. So this is another view. You can clearly make out that there is a fracture of the clavicle. Even without examining the patient, even without seeing the patient, if you see this X-ray, you can easily make out that there is a fracture clavicle here. And I think here there should not be any doubt. Is it broken? Can you guys talk back to me? Yes? How do you know that you guys are not sleeping? Anyway, you can clearly see. So what type of fracture is this? This is you can call it a segmental fracture, because there is a part of bone which is lying separate. So this is a segmental fracture of clavicle. So it's definitely broken. So classification, as I have already shown, this is the lateral end, this is the medial end, and common is middle 2/3, because the bone curves there, and in the curves you should always be careful. That's what they say. While driving also, whenever there is a curve in the road, you should be very, very careful. You should monitor how fast you are going in the curve. So in the curves here are very dangerous. That's where the fractures occur. We have seen 80% of the fractures occur there, and there are some muscles which are very strong muscles and very, very important muscles which are associated with clavicle, because they are attached to the clavicle. So in the medial end, sternocleidomastoid is the main muscle which gets attached anteriorly, and the other muscle which gets attached is trapezius. And coming to the lateral end, the two most important muscles which get attached to the clavicle are, one is pectoralis major and the other one is deltoid. So these four muscles, they determine the displacement of the fracture clavicles. So here there is a fracture here. The proximal fragment is pulled up. Why is it pulled up? By the action of sternocleidomastoid, because sternocleidomastoid is attached to the medial end. That's why, or the proximal end. That's why it's being pulled up. And the lateral, this is deltoid and the other muscles, and gravity of the limb, the upper limb is pulled down because of the gravity. So this distal fragment or the lateral fragment is pulled down. So this is a typical displacement of clavicle. You should know why this typical displacement occurs, because of the muscles which are attached. Once they start contracting, the sternocleidomastoid pulls it up and the gravity pulls it down. So there will be some displacement. Coming to the management. Usually the management is very simple, and that depends on the severity of the injury and the type of the fracture and the classification. We need to go into that to determine which is the best treatment option we have. So the simple thing which we have a sling or cuff and collar. Here the hand, we have a cuff around the wrist, and we have a sling, and we will attach like this. And with this simple mechanism, if you give rest for the patient for 6 weeks, I think the fracture will definitely unite. And sometimes if there is some displacement, then we need to use what is known as a figure of 8. Here 2 loops are passed through the axilla here and around the axilla other side, and they are tightly bound at the back. It looks like a horizontal figure of 8. So you should monitor the pulse when you put the figure of 8 in the patient. If it is too tight, because that comes into the axilla and it may press on the vessels, and there may be some vascular disturbance. So if pulses are normal, then it is okay, but you should be monitoring the pulses regularly whenever you put this figure of 8 bandage for the patient. And these things are commercially available nowadays. You can have a what is known as a clavicular brace or a figure of 8 you can available, and you can tighten it, and you can take it out when the patient wants to have bath or a wash, and it can be put again, and it comes with a velcro strap so that you can have the desired amount of tightness. And how long you want to keep this. And usually all of us know by now that all the fractures in the children, they unite much faster than in adults. That's why it should be 2 to 4 weeks in kids, and it is very difficult for us to make the kids wear this for more than this period. And luckily for us and luckily for them, nature is so great that the fracture can unite much faster in kids rather than in adults. And in adults it should be around 6 weeks, and patient should be mobilizing the unaffected joints. Meanwhile, from day 1 he should be mobilizing the joints which are not involved in the injury. Otherwise most of them may become useless after that because of the stiffness. See, the fracture clavicle is united but shoulder is stiff. That's a very, very bad way of treating it. So here, if there is a green stick fracture, we all know what is a green stick fracture. In green stick fracture, usually which occurs in children, there is a bend, not a break. Only one cortex is broken and the bone is not completely fractured. So we call that as a green stick fracture, and usually it should be usually what we do in a green stick fracture, we make it a complete fracture, then it will unite normally. Otherwise there may be some deformity, but luckily in clavicle it's not the case. So these are some of the things about fracture clavicle and indications for operation. Nowadays we are resorting more and more for surgical procedures to treat these fractures, and some of the indications are sometimes patient, there will be a bump. Obviously whenever a bone unites, there will be some callus. It's like 2 iron rods getting welded. Whenever you weld these iron rods, in the junction there will be some bump, but even in the bones there will be some callus, and this callus over a period it gets absorbed and it becomes normal, but it takes some time. But most of us, we don't want any bump which is clearly visible, because if you want to wear some type of maybe a collarless t-shirt or a jacket or something like that, the projection may not be, you may not appreciate that projection, everybody coming and asking what happened. So for cosmetic reasons, somebody may ask for surgical procedure, but even there will be a surgical scar. So the surgeon has to weigh which is better, and the patient may ask anything, but you should not jump just because patient asked it for cosmesis. And whenever there is a tenting of the skin, that means the injury is very, very severe, and in that a fragment of clavicle which is fractured may push through the skin or may tent the skin, which may lead to further complications. It may pierce out of the skin, making a compound fracture, or there may be a chance for infection and all. So you need to reduce these fragments back into place, and to keep them in position, sometimes you may have to resort to what is known as a surgical procedure. Or if it is an open fracture, all of you know that an open fracture is otherwise known as a compound fracture. Here what is open here is when the fracture is associated with injury to the skin. Whenever there is skin is not intact when with a fracture, that's known as a open fracture or a compound fracture. So the skin being most important, if you get a open fracture, open clavicular fracture, you may think of treating this surgically, because you need to provide the cover as well, because without without soft tissue cover or without a skin cover, no fracture unites. All of us know by now, because we have already seen in earlier classes that a soft tissue cover is a must for any fracture to unite. So these open fractures should be made into a closed fracture, then it should be treated, then they will unite much faster. Then if there is a vascular injury or neurological injury, because unfortunately for us, though the clavicle is a subcutaneous bone, it has very, very important, the brachial plexus and all those nerves which go into the arm and hand, they are just beneath the clavicle, and very, very important vascular structures are beneath them. So if the injury is very severe, then there may be injury to the vascular and neurological structures. If the fracture is associated with any of these vascular or neurological injuries, then definitely you need to repair them, and while repairing them, anyway you can fix clavicle. So this is what is known as a arm pouch or sling. So here the arm is protected, and the gravity, the pull of the gravity is also stopped by means of this bag, pouch, and this is connected round your neck. Okay, so that the gravity is eliminated in this. Once you eliminate the gravity, then the lateral or the distal fragment which is being pulled down is no longer pulled down, so that it stays in place, and it's very easy for you to maintain the position. So this is the simplest way of treating a clavicular fracture, and this is what I told you about. This is a figure of 8. So a loop comes through the axilla here, and another loop comes here, and both of them are joined here. So by tightening these things, you can adjust this. So once you reduce the fractures, you ask the patient to keep both his hands over the iliac crest, and what is known as a military attitude, and you stand behind the patient and you do the reduction. Okay, once you do the reduction, then you put this figure of 8 and tighten with these things here. So once you tighten, then this applies pressure over the fracture fragments and sees to it that they are relatively stable. Once they are stable, and it will be very easy to maintain this throughout the tenure of the fracture time before the fracture unites. But only problem here is, because this is coming through the axilla, if the pressure is more, then there may be vascular compromise. So you need to monitor the distal pulses, especially if you can monitor the radial pulse. You need to tighten this just before your pulse disappears. That is the correct amount of tightness. So if you tighten a bit more, then the pulse decreases. Then that is the point you should go back. Okay, so every day you can remove this and patient can have a wash and you can reapply. So these two are the methods by which we treat the patient conservatively, and these two are the procedures whereby we treat it by operative means. This is a plate and screws. So the fracture is somewhere here, and this screw is an interfragmentary screw which is keeping both the fragments together. So this plate is put on the superior aspect of the clavicle, and these screws traverse through and 3 screws on the lateral fragment and 3 screws on the medial fragment and 2 interfragmentary compression screws. So these keep the fragments together. So this plate is like a sling, but this is an internal sling. What is it doing? It is keeping the fracture fragments close to each other, stable. So once that stability is achieved, then the nature can take care and try to bridge the fracture and unite the fracture. So this is plate and screws for fracture clavicle, and the plate is applied on the superior aspect. And this is a intramedullary nail. Say very rare and very difficult procedure actually, because as we have already described, the intramedullary canal may or may not exist. So this is a difficult procedure, and we usually no longer do this. This is only for completion's sake. So you can operate on clavicle and fix it. So these are some of the slides which show the operative or surgical management of fractured clavicles. Coming to the fractures of the distal third. So it's a special entity by itself, and because there is some controversy over the management of these fractures. So they constitute a lesser part, that is 10 to 15% only, thankfully, and classification 1, 2, 3, and the severity increases from 1 to 3, and management conservative. Usually we do it conservatively, or sometimes operative treatment for 2 and 3. That's what they advocate. So here you can see a fracture distal third of the clavicle. So this is the clavicle, this is the medial end, this is the lateral end, and this is the acromion, and this is the shoulder joint, glenoid and head of the humerus. Coming to the complications. So no procedure or no fracture is without complications. So unless you know the complications, you may not be able to search for it and identify them when they are there. If you can't identify a complication, then it will be very, very difficult for you to treat. And if you don't treat a complication, then it is a catastrophe, because no treatment is complete without treating the complications. So in a simple clavicular fracture, it can injure a brachial plexus, great vessels or lungs, which are in close association with the clavicle. They are just beneath clavicle. So all these things, you should know that it can damage any of these things. So you should, while testing for, while examining a patient who comes to you with a simple clavicular fracture, that's what you think initially by looking at him. Or the patient may himself say that, doctor, I have broken my clavicle or collarbone, because that deformity is obvious. But don't jump to conclusion. You test, and once you find these things are absent, then it is very easy. Then there is some other term, a very interesting term. It's called a floating shoulder. How can a shoulder float? Okay, if there is a fracture on both sides of the shoulder joint, because all of you know by now that shoulder joint is formed by the glenoid cavity of the scapula and the neck of the head of the humerus. If there is a fracture on either side of the shoulder, then it is called a floating shoulder. Just for out of interest, I am just telling you should know that there is something called a floating shoulder. Floating knee is a certain clinical entity, and it's a very severe injury. We will be discussing that when we come for lower limb injuries. Coming to scapula. Scapula is a very simple bone. most of the scapula is taken up for muscle attachment, but the injuries are also fractures also very rare from heights. Then sometimes patients may come to you with scapular fractures, usually more common in males, that to around 30 years. That means adult males active because of work or recreation or otherwise. So the falls or driving, all these are more common in them, and usually they are more commonly seen, this scapular fracture in these males, and usually they are associated with other injuries. Isolated scapular fractures are very rare because they are in close proximity to either the lungs, ribs or clavicle. These injuries are usually associated with them. If the patient comes to you with a history of injury and tenderness over the scapula and arm adducted, maybe you could make a clinical diagnosis of fracture of the clavicle. And as always, you can feel the point tenderness at the site of fracture and crepitus, and sometimes you can feel the hematoma as well. Coming to the classification, you should always go for this classification, and most of the times the severity increases from type 1 to type 3. So here, this is the scapula, all of you know scapula, and type 1 is a simple fracture where the fracture is in the body or the spine. Type 2, acromion or coracoid process. Type 3 is scapular neck. This is a very dangerous zone because scapular neck and glenoid fossa, they are in close association with shoulder joint. So the fractures in the type 1 and type 2 areas, and they are not usually associated with shoulder joint, and the functional disability is much more limited in type 1 and 2 rather than in type 3 fractures. So type 3 fractures is very dangerous, and it needs lot of care in treating that. Coming to the shoulder, all of you know that shoulder joint is one sec. Shoulder joint is a ball and socket joint, and the head of the humerus, which is not completely a circular thing, articulates with a shallow glenoid cavity, and to increase the stability of the this joint, it is more mobility in the joints, then the mobility is a bit reduced. So when you compare a hip and shoulder, both of them are ball and socket joints, but in case of hip, the cup is very deep, the acetabulum is very deep, and the head of the femur sits very deep inside the acetabular cup. There the stability is much more than compared with the shoulder joint, where the cup is a shallow cup, and the articulation of the head of the humerus is not to that extent as head of the femur is with acetabulum. Whereas hip joint is very stable, shoulder joint is not so stable, but this is compensated by giving more range of movement to shoulder rather than to hip. So shoulder joint is much more mobile rather than the hip joint when compared with the hip joint. So nature has provided this because we need to get our food. By previously they used to hunt and all and do so many things. So for that you need a most mobile upper limbs rather than lower limbs, and lower limbs mostly they should be more stable while getting away from danger or something like that. So the mobility and stability, they are you should decide. So the shoulder has decided that it should be more mobile than stable, and the hip is more stable than mobile. And you see most of the movements in shoulder, and you can see even circumduction. What is circumduction? Circumduction is flexion, extension, abduction, adduction occurring throughout, say like 360 degrees a shoulder can rotate. But hip has its own limitations because of the deep cup. So shoulder is relatively less stable when compared with hip joint. So hip joint needs more energy for it to get dislocated, whereas a simple fall like our push, fall on the outstretched hand, can push a shoulder out. That means the head of the humerus can easily be pushed out of the shallow glenoid. So these are some of the important differences between shoulder joint and hip joint. And as most of you know that there are very strong muscles and strong ligaments in and around the hip joint when compared with shoulder joint. Shoulder joint has some muscles like rotator cuff muscles and some ligaments, but they are not so strong as the ligaments and muscles which surround the hip joint. Coming to the shoulder dislocation, you know what is a joint? Two or more bones coming together at a point, that's called a joint. And if they are in complete contact with each other, then that is a normal joint. If they are in partial contact with each other, then that is called a subluxation. And if they are not in touch with each other, then they are called dislocation. So now our college is dislocated. You guys are separate, the faculty is separate, and now we are doing something to bring them together. So this is one endeavor in that direction. So this is a dislocation is being reduced now. So shoulder dislocation, there are two types, anterior dislocation and posterior dislocation. How do you decide whether it is, how to call it anterior or posterior? If the head of the humerus comes anterior to the glenoid, then it is called anterior dislocation. If the head of the humerus goes back behind the glenoid, then that is called a posterior dislocation. I think they have given me around 45 minutes, and I think now I'll stop it here. I don't want to bore you guys even during these holidays, but if there are any queries, any doubts, feel free. I don't know whether I can see you or I can hear you. It's a one-way traffic, which usually I don't like, but these are difficult times, and yeah, if there are any queries in orthopedics or in COVID, you are free. You can freely ring me up and you can ask your doubts. You can consult me. There is no consultation fee for you guys. Yeah, telemedicine, it's dispensed freely for you. So any queries? Hello? వస్తావా? ఓకే.